Hello, everybody, and welcome to the MMOA podcast brought to you by the Institute of Clinical Excellence. My name is Annoushka Ranaraja. I'm Doctor of Physical Therapy and a member of the Modern Management of the Older Adult Division of the Institute of Clinical Excellence. Today, we're diving into a topic that I see misapplied frequently in clinics. We're talking about balance. Think about your schedule today. How many neuro, geriatric, or even post-op orthopedic patients did you have standing on a foam pad or standing in tandem stance? Probably a few. Now ask yourself this. How did you determine dosage? How did you measure the intensity? If we are training strength, we use percentages of a 1 rep max or RPE. If we are training cardiovascular endurance, we use heart rate zones. But when it comes to the balance standards, they typically are like, we're going to do like 3 sets of 30 seconds or a minute on a Bosu ball or a foam pad or in tandem stance, and we're going to see if they wobble. And then we wonder, why aren't these people getting better? Y'all, we have an underdosage problem. Today, we're going to fix that by discussing how to objectively quantify, apply, and progress balance intensity to trigger actual neural adaptation. To understand balance intensity, we have to stop viewing balance as a static skill and start viewing it as motor learning under stress. When you prescribe strengthening exercises, if the patient can do 30 repetitions easily without fatigue, the intensity is too low to stimulate hypertrophy or strength gains. Balance is exactly the same. If your patient can stand on that foam pad for 30 seconds while chatting with you about their weekend and they only lose their footing once or twice, you aren't training balance, you're just passing the time. True balance intensity is defined by the neuromuscular challenge and the rate of failure. If the task is too easy, no learning occurs because the nervous system doesn't need to adapt. If the task is too hard, meaning they fall over immediately every single time, the nervous system becomes overwhelmed, frustration sets in, and the patient resorts to compensatory strategies instead of effective motor corrections. So we want to make sure we're finding the sweet spot. So what is the ideal intensity? It's systematic instability with managed failure. We want our patients operating in a zone where they are visibly challenged. Think ankle strategies firing, hip strategies engaging, arms out for counterbalance. And they should experience a loss of balance or a complete loss of balance roughly 10 to 15% of the time. If they're succeeding 100% of the time, turn up the dial. So how do we turn that dial in the clinic? I want you to picture a mixing board in a recording studio. To increase balance intensity, you have 3 primary knobs. You can turn up or down basis support, sensory manipulation, or cognitive motor dual task. Let's break these down. Knob number 1 is basis support and biomechanics. This is your structural starting point. You can alter the geometry by going from wide to narrow stance to tandem stance to semi-tandem or single leg balance. But don't just stop at single leg balance. Change the center of mass, have them perform dynamic reaching, or introduce external perturbations. A gentle, unpredictable manual tap at the hip forces the nervous system to react to unexpected forces, drastically increasing the intensity compared to static holding. Knob number 2 is sensory manipulation. As PTs, we know the triad of balance: vision, vestibular, and somatosensory. If a patient has great balance on a flat floor, they might be heavily relying on their vision and somatosensory input. To crank up the intensity, take one away. So by doing that, you can diminish vision. You don't just have to have them close their eyes. They can perform saccades, following a moving target, wear drunk goggles, or if you want to alter somatosensory, you can use those foam pads, the AirXs, air discs, and incline boards. By making the surface compliant, you force the nervous system to rely less on ankle proprioception and more on that vestibular and visual input. Knob number 3 is that cognitive motor dual tasking. Real life doesn't happen while staring at a sticky note in a quiet clinic while it's on the wall. Real life is walking down a busy grocery store aisle while looking at cereal boxes, talking to your spouse. Clinical application for that, something I like doing is playing I Spy while walking down the hallway or going outside if it's accessible to you. If your patient has mastered those physical postural changes, you could increase balance intensity by adding that cognitive dual task. Have them count backwards by sevens from 100, name animals alphabetically, or catch and toss a ball while maintaining that single leg balance. This forces the brain to shift automated motor control to subcortical structures, which is exactly how we train functional balance. Now let's talk documentation and clinical utility. We need to document balance intensity with the same rigor we document load in a squat. Instead of just recording time, record the balance RPE or the failure rate. I like to use a modified Borg scale for balance, asking the patients on a scale of 1 to 10, where 1 is sitting in the chair and 10 is about to fall over every second, how hard was your brain and body working to stay upright? We should target an RPE of 7 to 8 for therapeutic intervention. You can also use something called the balance intensity scale, which we review in our Older Adult Live and Older Adult Level 2 courses. But this looks at various balance activities, and the patient and you get to rate how they approach activities, how they were during the activities, and then what it looked like while they're actually doing it in terms of if they lost their balance or not. So it's a very helpful tool to use and kind of subjective and objectively quantify that balance intensity. Additionally, documenting errors can be really helpful. So for example, with single leg stance on foam, eyes open with a cognitive dual task, naming words starting with the letter B. You could say the patient sustained posture for 30 seconds with 3 corrective steps required and listed 20 items. Next week, your goal isn't just to do it again. Your goal is to progress it if it's appropriate. If they drop down to 0 corrective steps, you must change variables. Switch them to eyes closed or change the cognitive task to something more difficult. And a quick safety note, high intensity balance training requires high intensity safety. So it might be helpful to use a gait belt or set them up in a safe space like a corner of a room. Make sure you're within arm's reach. Or if you have an overhead harness, utilize the overhead harness system. This allows the patient to feel 100% safe, but also keeps you safe with your patient. Because if you're holding their hand while they're doing some of these activities, you have inadvertently lowered that intensity back down to 0. They need to feel the edge of instability to learn. Give them the opportunity to fail in order to move forward and progress. I recently realized that I was helping a couple of my patients too quickly with balance activities. I wasn't giving them the opportunity to truly take that corrective step themselves or shift further on their own. As soon as I noticed that they were losing their balance, I gave them a little boost to correct that. So I've had to remind myself to give them time to take that corrective step before I step in to assist them. And I think that is a really key thing here is we can be afraid that we're not going to catch them fast enough if we don't get them right away. But if you set yourself up well, you should be able to still catch them if you allow for that extra second for them to take that corrective step if able. We want to make sure that they're safe, obviously. But again, it's just so important to make sure that they have that room to correct themselves because you're not out there in the real world when they're walking their dog and their dog pulls them and they need to take that step in order to avoid the fall. So that's really something I've been honing in on and I'm urging you to hone in on is make sure you're giving them room to take those corrective steps. And if they're not catching themselves at that point, that's when you step in to catch them. To wrap it all up today, stop treating balance like a passive time filler at the end of a treatment session. If you want your geriatric patients to stop falling, if you want your post-op ACL patients to regain true dynamic knee stability, and if you want your neuro patients to navigate the real world, you have to dose the balance to the point of challenge and give them time to react if able. Find that 10 to 15% failure rate. Turn the knobs on the biomechanics, sensory input, and dual tasking. Document the objective challenge and don't be afraid to let your patient wobble. The wobble is where the brain learns. And that's it for today's episode. Go out there, turn up the intensity on your balance interventions tomorrow. If you're interested in learning more ideas on how to manage complex patients, join us for a live or online course, which you can find at ptonice.com. Also, click the link below if you want to stay up to date on all things geriatric in less than 3 minutes with our MMOA Digest email. Thank you for joining me today.